Good morning. Thank you for the committee for inviting me. Discrepancies. It's quite a wide topic, and I gave a lot of thought of what to talk about. I think the first thing to say is that if a radiologist ever tells you they don't have discrepancies, they're either lying through their back teeth or they do no work. Unfortunately, we will all have discrepancies in our practice, and it's about trying to reduce the numbers that we have by sort of building systems into our reporting to try and identify where our weaknesses are. I mean, if I ever get a discrepancy, I do feel like this, but I think what you need to remember is to reflect on it and try and learn from that case. And is it a case that you just need to learn from, or is it a case your colleagues need to learn from as well? What I didn't want to do today was stand here and just show you loads of cases that people missed and went, look, this is another discrepancy, because what you'll see is it's stuff that we should be picking up all the time. A 4 or 5 centimetre tumour that's missed. It's a repeated theme. Obviously, there's a lot of things that impact how many discrepancies we make, having our phone on the table next to us, checking our emails while we're reporting. We all do it. We all know it's a bad thing, but we all continue to do it. So what I'd like to do today is to talk specifically about pitfalls in lower GI imaging. I'll do this because I spend 80% of my time looking at the bowel. I'm a very sort of subspecialist radiologist. I look at things from the DJ flexure down pretty much 80% of my day. So we're going to focus on that. Now, I have a bit of a declaration in the fact that I'm not a senior radiologist. I'm probably closer to many of you in the room than some of the other speakers later in the day. But I'm passionate about trying to reduce discrepancies, particularly in gastrointestinal imaging. What themes are we going to have? Well, we're going to look briefly at Crohn's disease. We're going to slip down to the appendix. We're going to look at small bowel obstruction, and then we're going to look at colon cancer. So we've broken it into sort of various pitfalls, and we've got 7 pitfalls in lower GI imaging. The first pitfall is not all terminal ileal inflammation is Crohn's disease, and then we're going to touch on submucosal fat deposition. So this is a conclusion I see quite a bit, particularly in our IBD-MDT that I take every week. There is terminal ileal inflammation in keeping with Crohn's disease. So we write this on an emergency scan that's come through ED or gone through the medical unit, surgical unit, and this is what happens. The patient gets prescribed prednisolone. They go for prednisolone for 6 weeks, 8 weeks. They eventually get seen by a gastroenterologist in clinic. Symptoms have got better, and we've labelled this patient with Crohn's disease based on a CT. And we all know the sort of gold standard diagnostic test for Crohn's disease is ileocolonoscopy and histology. So I see these scans in IBD-MDT, and I do this every week, week in, week out. And why? Well, let's look at the figures. 66-1. For every 1 admission of acute new presentation of Crohn's disease to hospital, we have 66 presentations to hospital with infective ileocechitis or infective gastroenteritis. So you can imagine that we are going to image a lot of those patients, and we have the potential to badge them as Crohn's disease. So how can we stop that happening? Well, it's about looking at the imaging and also about looking at the history of the patient, which often we don't have to hand because we get a very poor request saying right iliac fossa pain, not sure what's going on, and that's about all we have to work with. So this is a patient, they've got ileocecal thickening. You can see here, this is the cecum, very thickened, lots of stranding. There's some peritoneal reaction at the back here. This is the terminal ileum here, very thickened, and when we look here, we've got whopping nodes. This is infectious ileocechitis, all right? This is a small bowel ultrasound performed 5 weeks later, and this is the terminal ileum just before it comes into the cecum, thin-walled, totally resolved. So the history of that patient was an acute diarrheal illness. There was no weight loss, there was no long history of symptoms, long history of change in bowel habit. It was an acute presentation with infectious ileocecal. We've got a next patient, is a young man who presented with diarrhea and abdominal pain. And here we've got quite profound changes. This is the terminal ileum, coming up to a high riding cecum here, some cecal thickening as well. We can see some changes in the mesentery. We've got some hyper-enhancement of the mucosa. This was reported as Crohn's disease. However, if we'd have had all the clinical information to hand, this patient was on chemotherapy. This is neutropenic enterocolitis, okay, or neutropenic enteritis, this term of typhlitis. 6 weeks later, totally resolved, not Crohn's disease. So, what about Crohn's disease? Longer duration of symptoms. It tends to be ileal inflammation rather than ileocecal inflammation. You lose the gut signature if you do an ultrasound, the normal bowel layers. It involves the full thickness of the bowel, including the muscularis and the serosa. We've got these skip lesions, so look at the bowel elsewhere. Can you find other areas of ileal inflammation? We get fat wrapping. The nodes tend to be smaller and it often penetrates. What do I mean by penetrating? Deep ulceration, fistulation. Whereas infectious ileitis, shorter duration of symptoms, gives them an acute diarrheal illness. They may have pain. It tends to be ileocecal inflammation. The gut signature's maintained. We don't get bowel obstruction. There's no abscesses or fistulas. And often the omentum and the mesentery are clean and we get bigger nodes. This is from Radiology Assistant. We've seen a couple of pictures from their website already today. It's a fabulous resource, but this just gives you an idea that we can try and even work out what organism is causing the infectious ileocecal by looking at the pattern of disease we're seeing on CT. If you see this, call it Crohn's disease. It's highly unlikely to be anything else. We've got skip lesions, we've got fat wrapping, we've got nodes that are enhancing, we've got this beautiful cone sign in the mesentery. It's Crohn's, okay? More than happy to call that. The key is not the subtle things that we're subjecting patients onto prednisolone. So what's pitfall 2? Well, I often hear our registrars in the back of meetings saying this: oh my, he's ranting again. Submucosal fat deposition. This is what I mean. You see this area of, you've got the mucosa here, you've got your muscularis, and in this submucosa you get fat deposition. Now, often with that scan, it gets this report: submucosal fat in the terminal ileum in keeping with Crohn's disease. Guess what? Yeah. That's me and the IBD-MDT again. So what is the evidence? Well, there is very little good evidence, okay? But actually, if you look at all the papers, and I'm not going to sort of spend a lot of time on this, they do say it's related to Crohn's disease. However, it's a non-specific finding. It can be a normal variant. Normal intramural fat layer is very thin. It's a feature of chronic or subacute inflammatory bowel disease. Yes, it is, but it can be. It's not exclusive to Crohn's disease. So repeatedly getting that in the literature through sort of the early 2000s, and then a paper in 2016 suggested it is also related to obesity. However, there were a couple of papers that came in 2014 that, to me, answer all the problems. And these are a couple of reviews that basically come out and suggest at the end it's regarded as specific for inflammatory bowel disease. Okay? So how do we deal with it in day-to-day practice? Well, if it's an incidental finding or the patient's obese, do mention it in your body of report. But to me, the key is to look at the liver. Do they have steatosis? Can you make a difference to that patient in getting their GP to instigate lifestyle modification factors to stop them developing non-alcoholic steatohepatitis and subsequent cirrhosis? Why is that important? Our local transplant unit in Leicester is Birmingham, and they did more liver transplants for NASH last year than for alcoholic or hepatic cirrhosis. So there's a ticking time bomb of fatty liver disease. If there are other features of IBD, then obviously it may be related to IBD. It can be seen in celiac disease, and it can be associated with prior chemotherapeutic agents. Now, again, if you see a scan like this, where you've got thickening, you've lost the gut signature, you've got deep ulceration, beautiful fat wrapping with splaying of the vascular arcades there, and some submucosal fat deposition, well, it's Crohn's. Call it Crohn's. I'm not suggesting you don't, but it's just when you see it as an isolated finding. So what about pitfall 3? Well, this is one of my bugbears. Not looking at the appendix. Okay. We're all being pushed to do a lot of work. We're on call. I mean, I look at the amount of scans our registrars report overnight on call, and it's phenomenal how much they're getting through. But remember, there's a patient at the end of that scan. Give it the due it's worth, okay? So, appendix tumours aren't that common. However, we had about 30 cases in our hospital last year, and there's a suggestion incidence is growing, but whether that's just because we're finding more on imaging as incidental findings, it's difficult. But what is interesting, of those 30 cases, 43%, or 13 of them, had been seen, had been missed, but are seen on prior CTs. And of the ones that had been missed on prior CTs, 46% were advanced at the time of presentation. So we've potentially missed that window of opportunity for a simple operation to cure that patient of significant disease. So this is what I mean. In essence, when you're reporting a CT, we look at the liver, we look at the spleen, we look at the pancreas, we'll look at the appendix, build it into your review areas. And I mention it now in every report, so I remember it. So we look here, the appendix, just follow it up we come, and there, a tiny little enhancing nodule in the tip of the appendix. This is a patient admitted with diverticulitis. Actually, reporting this scan and saying there's non-complex diverticulitis doesn't make much difference to the patient, really. But what potentially makes difference to this patient is, again, red arrow, follow the appendix up we come, and there we go. Tumour in the tip of the appendix again. That will make the difference to this patient. Another case, this is in 2017, up we come, and then small tumour in the appendix. This is in 2018, got a bit bigger, missed again, and then this is in 2019 with an even larger tumour, and they had then peritoneal disease at this stage. So we've missed a window of opportunity. Now, there's a large appendix tumour on this CT, and you'd be hard pressed to find it because it looks like a small bowel loop. Okay, so run the appendix. Unless you specifically look at the appendix, you would miss this. And that's it in coronal. Actually, coronal review is quite easy, quite sort of beneficial, and you do see this tumour much better. 9 months later, this had fungated through the anterior abdominal wall, and we missed the opportunity to remove this appendix when it was simple isolated disease. This is a good pickup. This is an appendix here with little sort of enhancing areas and nodules on its wall that's coming into an inguinal hernia. This was removed due to those areas of enhancement, and it was a neuroendocrine tumour. Unfortunately, 2 years later, they developed neuroendocrine metastases from this primary tumour. And this is another case where we've picked up lots of peritoneal disease, big chunks of peritoneal disease here, and it was called query primary peritoneal disease, cancer of unknown primary, not sure, but actually if you go back and you look at this big chunk of peritoneal disease in the right iliac fossa, it is actually a grossly abnormal appendix, and this is a primary appendiceal neoplasm. So look at the appendix, okay? The other thing to remember is when you see appendicitis, look at the cecum, because the incidence of acute appendicitis as the presenting symptom of cecal or colonic cancer is about 3 to 15%, depending which paper you look at. So always go and look at the cecal pole. So, pitfall 4. Now, you're going to cover a bit, I think, on bowel obstruction at a later stage, but this is my take on abdominal x-rays. I don't think they're very good. I'll talk a bit more about why. So these are some older papers that show the sort of sensitivity and specificity of abdominal x-rays, but these were performed at a time when people were using abdominal x-rays a lot. We had experts looking at abdominal x-rays. The problem is the vast majority of abdominal x-rays that are done in my department don't get reported until the patient's gone home. All right, so then they're being looked at by juniors on the ward. They're not being looked at by people like this. This is my old mentor, Peter Rogers, who he was phenomenal and could pick up the most amazing things on abdominal x-ray that to this day, even though I report a significant number of abdominal x-rays, I will never reach that level of competence when it comes to abdominal x-rays. The people looking at abdominal x-rays are these guys on the ward. Now, I've never met any of these people. They were on a TV program, so I can't say that they're not very good at looking at abdominal x-rays. They might be very good, but evidence would probably suggest that they're not that good, all right? And it's these people on the wards who are looking at these images and making decisions on patient care. Now, if you look at NASBO, which is the National Audit of Small Bowel Obstruction, that suggested that over 80% of people presenting with query small bowel obstruction to hospital had an abdominal x-ray at admission. 70% also had a CT, so we're doing two tests in about 65%. But the mean time to CT was 2.2 days. Now, would any of you in this audience want to wait 2.2 days for the definitive investigation of the condition you've been admitted with? I probably wouldn't. And this is why. I mean, this on first appearances looks like a normal abdominal x-ray. I've shown this to about 1,000 medical students now and juniors, sort of F1s, F2s, and they've all pretty much, over 95% have said it's normal. However, to the trained eye, you might see actually lots of fluid-filled small bowel loops that isn't normal. And this was the CT performed a very short time later. Multiple fluid-filled small bowel loops with an obstructed hernia in the right groin. So you get this clinical information: previous laparotomy, abdominal distension, high-pitched bowel signs, vomiting, query adhesional obstruction. I would suggest you do a CT and not an abdominal x-ray. I think the key is, though, is all those requests we get overnight from the F1 or F2 on the surgical ward that say 25-year-old female, abdominal pain and vomiting, query obstruction. We don't do abdominal x-rays in those patients. They all go on to get an ultrasound the next day for cholecystitis or biliary colic. We're imaging a lot of people and just using this abdominal x-ray as sort of a tool to think, oh, well, we're doing something, it's okay for the patient. That's my own take on it anyway. And we've got to remember the gold sort of standard of imaging for small bowel obstruction is to identify complications of small bowel obstruction. Anybody can look at a CT and go, there's small bowel obstruction. What we are doing is trying to change the management pathway of that patient and say, right, you can be managed conservatively or you need to go to theatre, and helping our surgical colleagues make that decision. So that comes to my next pitfall. And it's not recognising ischemia as a complication of small bowel obstruction on CT. And that's because a lot of the time we do look at the dilated sausages and go, the small bowel obstruction, it's adhesional, and that's the sort of extent of our report. Unfortunately, though, if we miss the ischemia, this is what happens, is the surgeons get a bit angry and a bit upset, and sort of you look at the scan in retrospect and think, oh. And we know from the National Laparotomy Audit, NELA, that one of the biggest pitfalls and discrepancies between radiology reports and subsequent laparotomy findings is ischemic gut. It is very hard, but how do we look for it? Well, the first thing is decreased bowel wall enhancement or differential enhancement. So take what you think is a normal loop of bowel, enhancing normally, and compare it to the loops within the obstructed segment and see whether they enhance the same. The next key is mesenteric fluid, and it's actually the absence of mesenteric fluid that's important. In the setting of small bowel obstruction, there tends to be early venous ischemia due to obstructed venous flow, so you get stranding and edema in the mesentery. If there isn't, and it's absent, you can pretty much say that bowel is viable and there's no ischemia. That's not the same with acute arterial occlusion. This is purely in the setting of small bowel obstruction. And this is what we see. We've got normal enhancing loops here, and then these obstructed loops in the pelvis. You can't see the wall, it's almost imperceptible. Very faint enhancement here. Ischemic gut, needs to go to theatre. Similar appearance here. We've got normal enhancement of this wall here. We've got ill-defined enhancement, very little enhancement. Lots of edema within the mesentery, can't see the wall again here, and we've got a swirl in our mesentery. This patient needs to go to theatre, they've got ischemic bowel. I think the other thing to say is don't use positive oral contrast in the acute setting, because it really makes assessing this bowel wall and whether it's viable very difficult, because you've got this hyperdense contrast next to it and you can't assess the enhancement pattern here. And just a similar case again, obstructed hernia, look at the enhancement of this wall compared to this here. So this is an ischemic segment, needs to go to theatre. We've got one more helping hand though, because that can be quite subtle. And it's considering whether you do a non-enhanced CT within your protocol. And why? Well, we consider that because increased unenhanced bowel wall attenuation is a highly specific sign of ischemia. And what do I mean? Well, if you look at this scan, based on the ones we've just looked at, you'd say these are the normal enhancing bowel loops. And these are the ones that aren't enhancing, these are the ischemic segments. However, this is an unenhanced scan, and this is mural hematoma, blood within the bowel wall, i.e. dead bowel. Again, obstruction, needs to go to theatre, not be managed conservatively. And the importance of doing this non-enhanced CT is highlighted by this scan, because we look at all these loops. Yes, they're distended, there's some fluid, doesn't look quite right. This is an obstruction. This loop enhancing normally, these loops are enhancing normally. But if we go back a step and look at the non-enhanced CT, look at that mural hyper-attenuation, blood within the bowel wall. We're not seeing an enhancement of this bowel wall here. We're seeing blood within the wall. It's a dead loop of small bowel, which if we'd have only done a single phase examination, then we'd have missed that. Now, I'm not saying do dual phase CTs in all patients, but if there's a high clinical suspicion of complicated bowel obstruction, then do consider that. And again, same findings again, hyperdense bowel wall from a dead loop. So a non-enhanced CT can be beneficial in sick patients with small bowel obstruction. So, pitfall 6, can we detect colon cancer on unprepared or minimal prep CT? And are we good at detecting recurrence? Now, we get this history quite a lot. Change in bowel habit, iron deficiency anemia. They don't want bowel prep, they don't want an invasive test. Can you just do a CT to exclude anything big? This is the report that comes out, no significant colonic abnormality seen. Now, we're colluding with our clinical colleagues here because we can't really exclude it. We want to believe we can, but the evidence would suggest we can't. And the problem is our clinical colleagues may have read this article in Geriatric Medicine that suggests that basically turned round and suggested most studies give sensitivities of up to 100% to detect colon cancers, normal CTs. Not sure about that, because if we look at more extensively in the literature, we can pick about 75% up, 70%, 60%, we miss 20 to 30%. So we're missing quite a large proportion of colon cancers. So don't collude with our clinical colleagues. Why? Well, I'm going to show you. So we're not going to miss this cancer. This is a big, advanced rectal cancer. But what we will miss is the same patient have got this little tumour in their cecum. And a learning point is if you find one bowel cancer, 2 to 4% of those patients will have a second tumour at the same time. So try and find that synchronous tumour. Go and look for it. And then what about this case? This is subtle. I think it should be picked up, but I'd suggest it probably gets missed. And it was missed. Focusing on the descending colon, down we come. There's some asymmetrical thickening of this colonic wall, slightly rolled edge, and a couple of little nodes in the pericolic tissues, and again, a bit more thickening here. This is a T2 colon cancer, not picked up. Really subtle. Now, I don't want to turn you into overcallers. That's not my job, but it's just to try and sort of highlight the things that we can miss. And that's it in coronal. Again, I think running the bowel on coronal images is really useful. Again, this is a patient with an advanced rectal cancer. Look at this rectum. All we can see is just a little bit of asymmetry in the levators at the back. You're never going to pick this up. Hopefully they'll have done a PR when they were sending this patient for their scan to exclude a colon cancer. Again, I'm not sure whether that happens all the time, but really subtle advanced rectal cancer that you can hardly see. What about this one? Well, that's a whopping polypoid tumour in the sigmoid colon. To me, that almost looks like faeces, and you can see why someone had missed that. It looks very much like this. But again, on coronal, I think you'd be hard-pressed not to turn around and say, I think that's a tumour. Now, there's a 4.5 centimetre tumour in the bowel on this image. And I think you'd be very hard-pressed to see it. This was the MRI performed about half an hour earlier, and that is the large polypoid lesion at the sigmoid, rectosigmoid. That's the two scans next to each other. In retrospect, you can just about make this out. So it's not just little things we're going to miss in the colon, it's big whoppers like this and things masquerading as feces. So what are the tips? Well, focus on the rectosigmoid. It's a high yield area. Run the coronal and look at the pericolic tissues. Don't collude. Let our clinicians know how poor or what the sensitivity of that test is. So finally, what is the final pitfall? Well, it's not having all the information to hand. It'd be nice if we did. But one thing you can do is when you're reporting colon cancer follow-up imaging, go on your hospital blood test system, whatever it is, and look at the CEA, the carcinoembryonic antigen. Why? Because if it goes up, they've got recurrence probably somewhere, all right? It makes you look harder, okay? Subtle changes in the left pelvic side wall, subtle changes in the anterior abdominal wall. The key in this case was their CEA had been elevated. This wasn't picked up. And these are their two scans some months down the line showing recurrent disease. Again, similar here, this node could be deemed to be a bowel loop, but as soon as you put it in coronal, you see that this is peritoneal disease. Similar thing here, watch this coming down, and you can see how this big lump of tumour could masquerade as a small bowel loop, and again I'd suggest looking in coronal is a really nice way to pick up these peritoneal metastases. And that was it, again, some months later when it was finally picked up. Subtle changes here in the left adnexa. There was no mass effect here at this stage. 6 months later, you're now seeing an abnormality, and then this was confirmed on PET that there was a tumour there. So look at the CEA. If it's elevated, look harder. If you don't find anything, you then consider, should we do a PET? We tend to repeat the CT at an early interval and then do PET at that stage. So, not all TI inflammation is Crohn's disease. Obesity is the most common cause of submucosal fat. Look at the appendix. Consider doing a CT rather than an abdominal X-ray and small bowel obstruction, and maybe add in a non-enhanced scan to that protocol. Don't collude with colon cancer, and look at the CEA. Thank you very much.